So if you want to record, it's fine, just to help remember later.
Yes.
So, I guess I'll just start with my overview, if you like. You know, just to help get everybody on the same page and see if we make sure we're kind of all understanding each other and why you're even meeting with me and what are we doing here, why do we cancel surgery, what do we need to talk about, what are our expectations for this. There's been like a lot of back and forth, right? And sort of, I think, you know, I think we need to talk big picture a little bit before we talk about more narrow picture about how to deal with this. So what you were diagnosed with is, you know, original, I guess, bigger tumor that got removed eventually, and is a very rare type of sarcoma. Sarcomas in general are rare types of tumors. Your tumor we would classify as a B-core rearranged sarcoma. That's sort of the title of it or the type of it.
Okay. So like they just told me it was a spindle cell sarcoma, but it's actually got a different name, which is what?
A B-core, B-C-O-R, rearranged sarcoma. That's a genetic finding that's in your tumor that they found. And that sort of defines your particular class of sarcoma.
And so, like, if I'm Googling sarcomas and stuff, is this...
B-core rearranged sarcoma would be like the best type. It's a new, it's actually a new diagnosis that's only been created, let's say, in like the last 5 to 10 years.
Okay. Now, is it like like a more general? Is it like a liposarcoma?
So yeah, so it used to be in broader. So sarcomas in general are a group of rare tumors of which there's over 100 different types. And over the years, as we are doing these genetic profiling and finding certain mutations and genes that are involved, we're starting to sort of classify, you know, split them up into different things, even more so, into additional types of diagnoses. Sarcoma itself just means the cell of origin of the tumor comes from the connective tissue, not an organ. So most cancers are not sarcomas. They come from the breast, they come from the lung, they come from an organ, you know, the colon. These sarcomas are ones that come from the bone or the muscle or the fat or the blood vessels or the other connective tissues within your body.
And so the one that was in my back, was it in the muscle? Was it in the fat? Was it kind of both? Or?
It was sort of involving both, but you know, yours, this particular variety, we're not really sure the cell of origin, to be quite honest with you. We think it's within the connective tissue, within the usually the soft tissue spaces. So what kind of the areas where yours are, you know, near the muscles and bones and so forth, but not exactly the bone itself.
There's no bone was near right now.
Historically, before we found this genetic finding, which was this B-core gene, it looks most similar to a type of sarcoma called Ewing Sarcoma. And so in the past, it used to be called a Ewing Sarcoma variant. Ewing, E-W-I-N-G.
Okay.
And so Ewing Sarcoma is a tumor that under the microscope looks very similar to yours. To the pathologist, it looks, you know, they have the cells have the same shape and they look kind of similar to each other. Ewing sarcoma is a fairly aggressive type of sarcoma that tends to affect young adults and children, and has been well characterized now by a certain genetic event that is required for us to think that it's a Ewing sarcoma, a certain gene fusion. And in the past, there was, you know, 95% of tumors that look like Ewing sarcoma have this fusion within them, and then there's like 5-10% that don't. And they used to be classified as a Ewing sarcoma variant or a fusion negative Ewing sarcoma. And then we developed additional technologies to do genetic testing on tumors and additional genetic sequencing. And in some of those tumors, we found what's called this B-core fusion or B-core rearrangement. And that B-core is a certain gene that has gone bad in your cell that turned this cell into a cancer. And so this is now
no real cause of why it happens.
No real cause. We don't really know why this happens in most people, to be quite honest with you. And in most cases, we think that it's part of a bad luck event that's part of the built-in error rate of aging of our bodies. As one, you know, cell becomes two and, you know, tries to divide to grow to replace the old ones and replenish them, sometimes there's a lack of fidelity of you have to copy your entire genome from one cell to become two, so there's 2 copies of it. Each cell has a copy of it. And there seems to be a built-in error rate to that process as we age. And sometimes a mishap happens with that processing, gets inserted into the wrong area in the wrong cell, in the wrong contents, and et cetera, causes the cell to have a rearrangement in their genome that makes it prone to growing without signals. And eventually, if there's additional things happen within the genome of the cell, then it can sort of grow in an uncontrolled fashion, which is basically what a cancer is, a growth of a cell or a group of cells in an uncontrolled fashion.
Okay.
And so that's what I would label your tumor as, and that's a very definitive diagnosis, and it's a very narrow diagnosis. There's less than 100 cases of this in the United States per year.
Yay, me!
To give you an idea of how common it is. Even amongst sarcomas, which are overall are quite rare, yours is one of the most rare types within it.
So you guys are going to be studying me for a long time, huh?
Well, I mean, the only reason we know about it is that bigger centers like us keep track of things like this and try to find out, like, well, what happens when we treat with this or this, and how should we best treat these people, and what are the expectations. Historically, because it looked like the most like Ewing sarcoma, the most common thing was to treat the same way as we treat like Ewing sarcoma. And Ewing sarcoma is a sarcoma that we know that unfortunately surgery usually doesn't cure. And so we almost always recommend giving chemotherapy as part of the treatment for Ewing sarcoma. And over the years, as we've given more and more aggressive chemotherapies for Ewing sarcoma, the cure rate from it went up from about 20% to about 60%.
Oh.
So it went from like almost zero cure rate to at least most patients are cured, but still it's not perfect. And so that is how we treat Ewing sarcoma. A lot of people have inferred or said, well, this looks like it could be an aggressive cancer as well. We should probably give chemotherapy for this as well, because it's unlikely to be cured if we just do surgery. And so even in ones that are more localized and not spread elsewhere, we are often considering chemotherapy. In your case, I think we have to consider the status of it as well. I don't know how explicitly this has been told to you, but we would consider your cancer a stage 4 cancer.
The sarcoma, or the thoracic team did say, because it had moved into my lung, so how they explained it is that the sarcoma really won't go throughout your whole body. It'll just go through the blood, and the only place it will then attach itself would be in the lungs when the blood filters through the lungs, and when it goes through the lungs, it can either die or grow, and in my case, it grew.
So I think that is a partially accurate description of it, but I slightly disagree with.
Okay.
So that is, so I agree that what we found on your imaging in the lung is the sarcoma, and I agree that the way that sarcomas tend to spread in the body is through the bloodstream. A little piece of it or a cell breaks off from the original tumor and gets into the circulation, and the lung is where the circulation tends to filter into, and that's where they tend to deposit. And that's where they tend to grow additional sites. You know, one cell or one clump of cells can grow into these nodules or tumors. I think of it like a weed or something like that. Even if you take out the original weed, there might be some seeds out there, or they may have already spread ahead of time, or maybe you can already see that they grew a second weed somewhere else because one of the seeds have broken off. And so that in your case is what we see, I believe, already. And we see at least one spot in the lung and probably a second one, that are two different areas where these seeds are starting to take and starting to grow.
Is that the one that's on the left side?
Yes, ma'am.
Okay.
And so that's what makes it cancer stage 4, is whenever we see the ability for them to seed and grow elsewhere, we consider them stage 4 cancer at that point. And even though the lung is the most common, it's not the only possible area, although some people we only see it develop in the lung, and some people we can see it end up in other areas because of the bloodstream spread as well. So one thing that I do recommend doing at the outset before we definitively decide what to do is to do more of a full body scan as well. One, to check on the lungs, how since it's been.
Scan?
I think, we could do either a full body CAT scan or a PET scan.
I don't really know what a PET scan is, but everyone keeps asking me, have you had a PET scan? Have you had a PET scan? And so
I think for this diagnosis, it would be, I think it would be worthwhile to check a PET scan once. It's a bit more of a a bit more of a full body scan that adds the additional element of this PET level activity, which gives sometimes an indication that you can pick up things smaller in a more sensitive way.
In a PET scan, how do they even see these minute particles of cancer?
So there's still a limitation. There's still a limitation of what you can see on this PET scan, and usually you still need things to be about at least half a centimeter to a centimeter before you can see on a scan. That's the resolution of all these things. So we can see things that are about this big, but you're right that we can't see microscopic amounts.
But then if they see something and it's like, oh, that's just an odd-shaped thing that doesn't look like it should be there, is that how they...
Generally, that's what we see on CAT scans. We see something where it shouldn't be. So like we see a small, solid, round-looking nodule in the lung where it should be mostly airways and so forth. That's how we found what we see now. The PET scan adds another layer on top of that, where they give a radioactive version of glucose, which is sugar, and sugar is taken up by your body to use energy, and so anywhere that's taking up more energy in your body picks up more of that tracer, and so some areas kind of light up a little bit based on that. And so this tends to collect in some areas of your body, like the heart, which is using a lot of energy, your brain, which is using a lot of energy, but tumors also tend to use more energy than your bones, your muscles, etc., because these tend to be growing faster than these other areas of your body. They're regenerating themselves at a faster rate than your normal body would, and so it sometimes gets picked up by these tumors as well, and can sometimes highlight them a little bit to the radiologist, help them see them as well. And so the PET scan in some cancers is slightly more sensitive than a CAT scan. For this rare one, we're not sure, but I think it's worth checking once to do, as well as to do the full body check to see where everything is, to ensure that all we're dealing with is one or two, a couple of spots in the lung. So I think that is something we should do first before we start going into surgery. The other thing is that I think we should very strongly consider chemotherapy before we start getting into surgery. And the reason for that is frankly a reason of futility of surgery. And the reason for that is because when we see a pattern like this, when we know that this tumor has already seeded several areas in the lung, there is a over 95% chance that there's other microscopic amounts out there that we do not see on a scan. And so even if you remove the ones that you see, there will still be residual cancer that you can't see, that will eventually be seen on a subsequent scan in a few months, or in a year, or in 6 months, or something. And so there's a measure of futility to taking out what you see once it's already become stage 4. And the times that we've seen and so frankly, you go through multiple surgeries for that, just end up in sort of the same spot a few months later, oftentimes. And when we've had the greatest success from doing that is when we've had, and frankly, the cure rate for doing surgery for a situation like that is pretty low. Like I said, most of the time, over 90% of the time, you see them end up in additional spots. And most likely, other spots in the lung is most common, but still possible elsewhere too. And so, where we've had the greatest success when implementing surgery as part of it is when chemotherapy is, where we've had a demonstrable period of time where we've not seen new areas come up, and or either naturally by just monitoring it over time and it just happens to seem isolated, or when we've used chemotherapy as part of it to sort of maintain, lack of spread elsewhere, and then using surgery more of a consolidation or taking out what's left or residual. That's when we've seen the greatest success to these approaches, where we use surgery on the back end to do that. And so I think when you've come to the point where we consider this to be a stage 4, I tend to be very strongly inclined for chemotherapy, even before we kind of be going through multiple operations for that reason. And using that logic and rationale. And so I think that's what we should do in your case, even if the scan only shows the 2 areas in the lung. And
what's the difference between, or you hear a lot about immunotherapy now, so
yeah,
not recommended for what I have.
For chemotherapy is obviously just putting a poison into the body to try to poison the whole, anywhere that it might be, including microscopic amounts. And that's sort of the more traditional way to treat cancers that are advanced. There's this newer variety of therapy called immunotherapy that we're using in some cancers nowadays. It's been, changed our practice for some. The thought process behind these immune therapies is that maybe you stimulate the body's immune system and it can fight the cancer, or recognize the cancer as being wrong, and combat the cancer that way. For some cancers, it's been extremely promising and highly effective, and melanoma is a good example. That's where a lot of it was tested in the first place. And for melanoma, for example, it's completely replaced chemotherapy altogether, and it's much more effective and much more likely to have a long-term effect or remission that lasts. Whereas chemotherapies for a lot of cancers has an initial effect, but is not always durable. Often can develop resistance. Often doesn't eradicate it completely. For other cancers, the immunotherapy just hasn't worked quite as well for some reason. It's just not been as much of a reactive type of cancer to your body, and the success rate's been lower. For melanoma, the success rate's about 50-50 actually with these immunotherapies. And we consider that to be great, because it used to be essentially a death sentence when you had stage 4 melanoma, but now there's a 50-50 chance you can go to a remission that could be 5-10 years lasting. In other cancers though, and for example, most breast cancers, except for the triple negative variety, the response rate to immunotherapy is minimal, like less than 10%. Chemotherapy is still more effective. For lung cancer, it's sort of in between, similarly level of effectiveness to chemotherapy. For sarcomas more generally, the success rate to these immunotherapies has been in the ballpark of about 10%. We've tested it in several trials using the drugs that have been most successful in melanoma and other cancers, drugs that you see on TV like Keytruda.
Yeah, I was reading about that. I kept hearing advertisements, and then I was never paying attention. But
there's advertisements because there's two different drugs that do the same thing, and they're competing with each other. So now they get advertised to try to get on the market. One's called Keytruda, one's called Opdivo, and so we've tested both of those in sarcomas, and again, the success rate's been about 10%. If you take all types of sarcomas together, Ewing sarcoma hasn't had a very good success rate at all. For whatever reason, doesn't seem to be a very active tumor. For the B-core rearranged sarcoma, I don't think it's been. It's so rare that we haven't really tested that extensively. And so I don't know if it's an immunoreactive tumor, but I have not seen any cases reported yet that have responded to immunotherapy of this type. Although it's probably very few that have been tried. And it does tend to respond pretty briskly to chemotherapy. And so we do think that chemotherapy helps improve the chance of surviving this tumor for most people. And so we are sort of inclined to try that still first.
And so the type of chemo, what type is it? Is it drugs? Is it pills? Is it?
It's infusions. And so it's a combination of various toxins that are infused over a period of days to try to poison this as strongly as we can.
So I have to come on site somewhere, and
so you have to come. So we would have to put in a port to help administer the chemotherapy. You have to know what that is. It's like an IV that's underneath the skin that's semi-permanent.
I saw somebody's recently.
And so we'd have to put in one of those, and then we would schedule you to come in and get a round of chemotherapy. And so you'd be with us for a few days, and almost a week, let's say, for 4 or 5 days, and getting infusions and IV fluids.
Stay the whole time?
Well, this one we actually do tend to administer the first round as an inpatient, where we actually keep you in the hospital to give a lot of IV fluids and monitor to make sure that the tolerance of it is okay. There is a route to give it by coming in daily and staying here for, long days, for multiple days in a row, and getting it that way as well.
And it's all done at this site?
Yes.
Okay. Do you have any sites in Pinellas County or other places?
Unfortunately, we don't for this, because this one is a bit more of frankly, a little bit more of an intensive chemotherapy that we tend to like to be people at our home site where we have the most experience with it and closest monitoring for it, and it's given over multiple days like that.
And so, what would be the general schedule?
The general schedule is that you get the chemotherapy over a period of 4 or 5 days, and then you have the effects of that for the next couple of weeks, and we do call it a 3-week cycle. And so the 3 weeks from the start date of the first one is when we anticipate doing the next one. And that's by design, because that's the general recovery period for these things.
So it's one week of it, then like 3 weeks off?
Well, 2 weeks off after that, essentially.
And then how long would you anticipate having to do this cycle?
Well, if we were to do this, I would do 3 rounds of this, and then see how, basically do before and after pictures and see how it looks.
Okay, so 3 rounds.
And so it's not not quite 3 months of treatment before we see how it's doing. Depending on the level of effectiveness, if we're extracting from Ewing sarcoma, most people, if it's working well, tend to give 6 rounds of it total, and then if there's anything left, do either surgery or focused radiation to take care of anything that is residual at the end point. And that's the most common way that this is dealt with.
So it sounds like the first round is pretty tough, huh?
Well, I'd say I'm not sure how tough the round is going to be, and depending on how tough it is, we would consider doing every round in the hospital, or sometimes if it's not as rough, we would consider doing some of them as an outpatient, meaning coming in for the daily infusions and going home at the end of the day. But I'd say for the first one, we prefer to do, actually admit you to the hospital so we can closely monitor and have the nursing staff there and be able to give you lots of hydration through the IV to help make sure it's flushing the system and so forth. It's in, IV medications for nausea throughout the day and things like that.
Mm-hmm.
And so it is a fairly, moderately intense chemotherapy, and you do feel the effects of it even when you're, finished the infusions. It takes a couple weeks to recover. It has, that's why you have to wait a couple weeks before you're ready for the next round.
And what would I generally feel like? Because I've got stuff planned at the end of July that I can't really change.
Well, most people are very fatigued when they're on this, especially during the time that they're getting it in the next week. That's the most common side effect, and there's a 100% loss of hair rate. Like, I don't think I've seen anybody not lose their hair with this chemotherapy. And then there's some degree of other stuff too, feeling nausea or just not like eating. And some people have other things too, like, you know, nerve tingling, mouth soreness, or, you know, rashes. You know, there's other things too, but the one thing that everybody feels is fatigue, to varying degrees. I've had some people that have gone through and been like, you know what, I lost my hair and it was, you know, I felt off a bit, but I was okay. And I've had some people even like work part-time when they were not getting the actual, you know, their recovery weeks. But, you know, I've had some people that have gone through this and be like, man, I can barely get out of bed for a week straight after I got out of that dosing, and just finally started to feel like a little bit closer to normalcy when I was ready for my next dose, and was pretty tough for the whole round because of that. You know, it affects your blood counts, and it can make you anemic while you're going through it. Some people get anemic enough that we actually have to give them a blood transfusion to get them, you know, support them through it. You know, infection risks and things, you know, it's tough on the body. It's chemotherapy, and it's you know, the general health and so forth, and age affects how well you tolerate it.
I mean, I'm super healthy other than having sarcoma in my...
So I think that you would like to be okay with it, but it still can be rough for some people, and you know, that's why we want to at least monitor the first round to see how it goes.
So best to probably not start this until after I get back.
Well, I don't know. I mean, I think it depends on what you have going on. You know, but yes, it would. You definitely would be affected by it.
My son is going to camp, architecture camp in North Carolina, and we're doing college tours, and I have a tiny house being delivered that I have to go get set up during that week that he's at camp, and so it's...
I think it would be very tough to do all that while you're doing this, yeah.
Oh, yeah.
So best to wait until I get back in early August.
Yeah, I mean, it's tough. I mean, obviously there's a little bit of anxiety to start the treatment, right, on this.
Right.
And,
well, I mean, Jonathan can drive, and...
You know, but on the other, you know, and so you don't, can be an aggressive cancer, and it's frankly, it is one that I think I don't know how it's going to go in your case. I don't know if we'll be able to get rid of this cancer in your case, but this is going to be the best chance. I'm talking about the best, you know, we're talking about something the best chance of surviving this. Right? You know, it's pretty serious stuff.
Is this the kind of cancer you can live with? I mean, I hear people say, I live with cancer.
I would say that this is usually not the type that is, well, I guess it depends what you mean by that. You know, it's not one that typically people can live a very long period of time without doing anything to. It's usually one that within a year or two starts becoming like, you know, terminal cancer once it keeps going out of check. It's not one that usually people are living 5-10 years without any treatments and growing slowly. It's usually one that's a bit more.
So what is it doing? Like when it's growing in my body, it would just consume my lungs so much that I couldn't function?
At some point, if it got bad enough, it could start compromising your lungs, yes. Okay. If it got to enough of it. Obviously, it's far away from that, but depending on the growth rate and things that we're not sure of yet. I mean, it didn't change rapidly over the time we've been tracking you, you know, which is only a few months though, right? But
well, I thought it changed rapidly enough that they were pretty concerned.
But it's changed enough that we have noticed at least a little bit of a change over that period of time.
Right.
Yeah, I don't think in the current trajectory it's going to change to the fact that it's going to start compromising your lungs in a few months, but could it start compromising your lungs in, you know, a year? Definitely could. Could it start compromising
I wouldn't wait that long. I would wait until I got back.
Could it start compromising in
trip.
6 months? It certainly could. So I don't know. There is a little bit of an urgency to it, and usually a week or two here or there does not make an ultimate impact on these things. And we do. I mean, it is already at stage 4. It's not like it's like we're talking about catching it before it spreads, because it's to some degree that's already, the cat was already out of the bag when we started.
Right.
But you know, at the same time, it's not something I would want to wait months on either. Personally, you know, I think it's one of the things that lower the burden or other things. But if you have a lot of things going up, you know, soon, and you need a 1 month, you know, wait before we get into this.
I've got to come in and get the
then I think we can
CAT scan and the PET scan.
That's right. So I think in the meantime we can take care of those sorts of things, and so anticipate doing it in about a month. I'm comfortable with that because you have a lot of life things going on that's important in your life. Right. And I think it's pretty unlikely that a month is going to make a difference how this ultimately turns out. I think how this ultimately turns out is going to depend mostly on how well your cancer response is, which is a little tough to predict. Most of them respond pretty well, but you know, I'd say that the permanence of the response is in question. You know, chemotherapy can be pretty effective for these sometimes, but it's not always eradicative, and often not. When you know, it helps treat the best case scenarios. It treats the areas we don't know about, and the ones we do have a good response. if there's anything left after the response, we might consider surgery at a later point to remove what's left, or focused radiation, depending on what's left. And
whatever, I'll do what I have to do. So.
But I think that, in my opinion, it would be more logical to one, get a full body staging as a baseline here, just to make sure we're comfortable with the degree of what we're dealing with.
Right.
But almost irregardless of that, I would be more inclined to start with chemotherapy and with this type of sarcoma, and with, frankly, the degree of spread we see already, even with just the two areas. I think in somebody that's healthy enough to go through that, I think it improves the odds and would be the better route to go. I'm sorry there's been so much confusion around this, and with all the changes and things, and also just to, I'm sorry that you're going through this in general. It's not something you wouldn't be telling anybody, and I hope at least I could give you a little bit of clarity of what we feel about this and where we stand and what we're dealing with.
It's a long-term prognosis, because I've always felt this is not a big deal at all. I just had a thing, I just had it removed. It hasn't been a big deal, blah blah blah. So it's getting a little harder now. It's like
I think it's a little bit. I think I'm talking about something that's a little bit more guarded prognosis, big long term, and a little bit more worrisome than maybe that we had appreciation for before. And I think part of my goal meeting you today and discussing this big picture is to really focus on that, because I think the surgeons who are great surgeons that you've dealt with and stuff are really focused on, they're part of it, getting the surgery in and dealing with that, but I'm not sure how much of these big picture things we've delved into in this level of detail with you.
Not at all. So.
Probably, and so we're probably overdue to meet with you and do that after you recover from your surgery.
Okay. And it doesn't matter the day of the week, because you guys are, like, if I came in to start this in the middle of a week and stayed over a weekend or whatever, it doesn't really matter.
That wouldn't really matter so much, no.
Right. So it doesn't have to be Monday through Friday, or it could be Wednesday through Sunday.
Yeah, not necessarily. We sometimes tend to do like Mondays or Fridays for admissions. It just seems to flow a little easier, but we are kind of flexible in that regard.
Just, trying to figure out when I get back from
day one
college tours with my son, and it might be the middle of the week, but then school starts the next week. And
we can try to work around that to some degree, and again, shifting things a day or two here. The only thing we wouldn't admit you start the first day number one would not be over the weekend. That's the only limitation.
Okay, so we just make it back from college tours and just.
I think that you have a lot going on right now in your life, and you need to take care of your children and do these things that are important in life. And I think that that's a priority, and I agree that you should not cancel all of that so that you can take care of those important life things that you need to do. I think
that's helpful.
I think that's
if we wait a month, it's not gonna.
I think that we should. I think that we need to get sort of the port put in at some point while you're in town, in anticipation of getting chemotherapy, and get a.
So that's beforehand.
Full body scan. Well, you can get that at any time. It stays in for the whole duration. So yes.
But I would do that prior to
starting chemotherapy. Yes.
Oh, okay.
Yes.
When you're here for it.
It's an outpatient procedure, yeah. So one of the days you're here, let's say.
Okay.
Between trips or whatever, getting ready.
Before I leave.
Or before you leave, even you could get it put in. It looks like almost like a pacemaker. It's underneath the skin. You can travel with it, etc. So if you wanted to get that done before you leave, you could. The
outpatient,
scan,
so there's no real recovery for that. It's just
it's a day procedure. You go home the same day. Okay. What else? The scan, I actually would probably prefer to get closer to the start date of the chemotherapy. So when you return from your trip, I would prefer to get that, because again, we'll be using that for later comparisons as a baseline of how well the chemotherapy is working.
So we don't need scans now?
I think if we're going to anticipate delay, sort of having this small delay in treatment by about a month, I'd actually prefer to get it closer to the start date, like when you return.
Okay. So
we can schedule that for when you're going to be back in town after you've done some of these trips, like for 3 or 4 weeks from now or whatever. I don't know the exact timing of your stuff, but we can schedule that for towards the end of July when you'll be back.
Well, the end of July is when I'm gone.
Mm-hmm.
So,
When are you coming back?
like the first couple days in August. That was
Or maybe maybe we schedule in the early August then.
right. Just wanted to try to get in and out of the hospital before the first day of school. So, which is August 10th.
Stay with us. I know you want to be there, Chris.
In the hospital's first day of school. And he's a big boy, he's going to be a senior, but still. Okay. Well, we'll get it figured out.
Yeah. Well, I think, that we could certainly target, getting scans like whatever the, day after you get back or whatever, and admitting
Right.
over that week even, and trying to get you out of the hospital before that first day of school.
Yeah.
And, but, it's going to be tough. I mean, you have to talk to your family about this either day, It's a tough conversation to have with your children. You're dealing with something, you dealt with a bad hand with this, and it's going to be a difficult road ahead again.
And she's a realtor, and her only means of income is
It's fine.
working.
It's fine. I can use the.
Yeah,
I have that cancer policy that also has disability built in.
We may have to consider that for part of the time, depending on how things are going. I think, obviously, like I mentioned, some people work part-time, but it's pretty involved even if you're trying to do that. And you may consider even, disability for a couple months or something, at least while you're initially going through this to see how it's going. I would probably recommend considering doing that if that's possible for you to do that.
I can do that. I paid for that policy, so I can use it.
Yeah, I think you have a few things you've got a lot going on, obviously, in your life right now, and those are important things, but, we're going to have to shift the focus onto this.
Yeah, no, this is important too.
pretty soon, I think.
Yeah.
There's just, unfortunately, there's no way around that. And I think
We'll
that's,
make it happen. Maybe we have to go to the Virginia schools before, do that earlier in July, and then just come home right after his camp or something, so I don't know, figure it out.
maybe there's a way to consider that, yeah, I don't know.
Just shift those dates, it just made more sense geographically, but whatever, I can change it. So, then we can go to Virginia in the fall. No, I can't do that because I'll be having cancer treatment, so. Alright, we'll figure it out.
Yeah.
I'll try to get back by beginning of August. So.
Yeah, I think that's a good target to shoot for.
Yeah, I'll just do this at the beginning somehow.
So that's what we're gonna do.
Okay.
We're gonna figure the things taken care of at a time so that we're ready to go as soon as you're ready to go with your other social issues, taking care of these other things that are important in your life.
Okay.
And I think that covers it.
In the meantime, what's